You know that feeling, that deep, bone-tired exhaustion that just doesn't make sense, or maybe a headache that hangs around, or even like a weird, persistent itch after a warm bath?
Hmm.
Sometimes our bodies just crank things up without us really knowing why.
Yeah, that's a great way to put it. And it sets the stage perfectly for today's deep dive into Polycythemia Vera. PV, for short.
PV, right.
It's basically a condition where the bone marrow, the blood cell factory, it starts overproducing. It's classed as a myeloproliferative neoplasm.
So like the marrow's working overtime?
Exactly. Making too many of certain blood cells, particularly red blood cells.
Okay. And we've got some really thorough revision notes here, perfect for anyone prepping for the MSRA, actually. They cover PV from, the basics right through to the long-term picture.
Yeah, they look comprehensive.
So our mission today is to really dig into these notes, pull out the absolute must-knows, the high-yield stuff for revision, and make PV feel a bit less daunting.
Absolutely. Break it down into manageable, memorable bits. So let's start right at the beginning. What exactly is polycythemia vera?
Okay, so fundamentally, it's about this thing called clonal proliferation. Basically, one slightly rogue cell in the bone marrow starts making loads of copies of itself.
Hmm.
And in PV, it's the red blood cell line that goes into overdrive, so you get way too many red blood cells.
Right, which leads to that increased red cell count, higher hemoglobin, and critically, a higher hematocrit, that measure of how much of your blood volume is red cells. Makes the blood thicker.
And it's a primary polycythemia. The notes stress that, meaning it sort of starts on its own, no obvious underlying trigger like low oxygen or something.
Precisely. It originates in the bone marrow itself. You might also hear it called Polycythemia rubra vera rubra, meaning red.
Ah, rubra red. Makes sense. And it's not always just the red cells, is it? Often neutrophils and platelets are up too.
That's a key point. While the red cells are the defining feature, you often see increases in certain white blood cells, the neutrophils, and platelets, which are involved in clotting. It's often a multi-lineage thing.
Okay. And the big player here seems to be this JAK2 mutation.
Huge player. The JAK2 V617F mutation specifically, it's found in around 95% of people with PV. Think of JAK2 as like a signaling protein that tells cells to grow.
Uh-huh.
This mutation basically jams the on switch. So the bone marrow just keeps getting the signal to produce more cells, even when it shouldn't. It's massively important for diagnosis.
95%. Wow. And this usually appears later in life. Sixth decade, so 50s, 60s.
That's a typical age range, yeah. Peak incidence is around 60, 65.
And initial symptoms can be quite vague, like fatigue, itching.
Very much so. Fatigue is common. Pruritus, that itching, especially after a hot bath, is quite characteristic. And a large spleen, splenomegaly, is often found on examination. And, importantly, there's that increased risk of thrombosis, blood clots.
And it's a chronic thing, but it can sometimes change over time. Progress.
It can. Over many years, there's a risk of it progressing to myelofibrosis, where the marrow gets scarred, or, in a smaller percentage, transforming into secondary acute myeloid leukemia, AML.
Okay, so maybe a memory tip. You suggested PV, so you really read plenty of viscosity.
Yeah, just something to anchor it. Primarily red cells leading to thick, viscous blood.
Got it. Okay, so that's the what. Now the why. What's the actual cause, the etiology behind that JAK2 mutation?
Well, as we said, the JAK2 V617F mutation is the main driver. It messes up the normal cell signaling pathway, specifically the JAK-STAT pathway, that control growth.
So it dysregulates things.
Exactly. Leads to that uncontrolled proliferation of red blood cells, mainly.
And it just sort of happens. It's not usually inherited.
Generally, no. It occurs sporadically. It's an acquired mutation, not usually passed down in families.
Yeah.
Why that specific mutation happens in the first place,
It's
though,
still a bit of a mystery.
still not fully understood, no. We know the consequence of JAK2 activation, but not always the initial trigger for the mutation itself.
Okay. What about risk factors? Who's more likely to get PV?
Age is the big one. Definitely more common in older individuals, peak in the 60s and 70s.
And slightly more common in men.
Yes, there's a slight male predominance noted.
Any environmental links? Radiation or anything like that?
There have been some suggestions, some associations looked into, but the notes are clear that specific links aren't really well established. It's not like there's a definite environmental cause we can point to for most people.
So mainly age and maybe being male. Right. Let's dive a bit deeper into the pathophysiology. What's happening at the cellular level once that JAK2 mutation takes hold?
Okay, so you get this clonal expansion. One stem cell with the mutation starts dividing and takes over, producing lots of daughter cells all carrying the same mutation.
And that mutation leads to constitutive activation of the JAK-STAT pathway. Sounds technical.
It does, but basically it means the pathway is switched on all the time, permanently active, even without the normal external signals like hormones telling it to activate.
Like a faulty light switch stuck in the on position.
Exactly like that. And this on signal promotes the proliferation, the growth of not just the red cell precursors, the erythroid line, but often the myeloid cells, white cells, and megakaryocytes, the platelet producers too.
Which is why we see everything go up: red cells, white cells, platelets in the blood tests.
Precisely. Elevated hematocrit, often leukocytosis, which is high white cells, and thrombocytosis, high platelets. It's all driven by that constitutively active JAK-STAT signaling from the mutated clone.
Okay, that makes sense. Now, if someone comes in with, say, a high hematocrit, how do doctors differentiate PV from other things? This seems crucial for MSRA prep, the differential diagnosis.
Absolutely vital, because other things can cause high red cell counts. First, you've got relative polycythemia.
That's where the plasma volume is down, dehydration maybe.
Exactly. The red cells are more concentrated, but the total number isn't actually increased. It just looks that way because there's less fluid.
Right. Then there's secondary polycythemia.
Yes, this is where the body is making more red cells in response to something else. The classic cause is hypoxia, low oxygen.
Like from lung disease, COPD, or living at high altitude.
Correct. Or, less commonly, certain tumors can inappropriately produce erythropoietin, the hormone that stimulates red cell production.
So in secondary, there's a reason for the increase, whereas PV is the bone marrow going rogue on its own. What about differentiating from other myeloproliferative neoplasms like CML or essential thrombocythemia?
Good question. With chronic myelogenous leukemia, CML, thrombosis is generally less common than in PV. And crucially, CML has its own specific genetic marker, the Philadelphia chromosome, or the BCR-ABL fusion gene. That's usually absent in PV.
Okay, so that's a key differentiator. And essential thrombocythemia, ET.
ET is mainly about too many platelets. While PV often has high platelets too, the defining feature of PV is the high red cell count, which isn't typically seen to the same extent in ET. But there can be overlap, which makes diagnosis tricky sometimes.
So you really need a comprehensive workup, including that JAK2 test, to pin down PV.
Definitely. Along with checking erythropoietin levels, looking for secondary causes, and sometimes bone marrow examination.
Right, let's try that example question from the notes. A patient presents with an elevated hematocrit. Key distinctions between PV and secondary polycythemia.
Okay, key things. 1, look for underlying causes of hypoxia or tumors. 2, check the serum erythropoietin, EPO, level. It's typically low or low normal in PV, but normal or high in secondary. 3, test for the JAK2 V617F mutation, present in 95% of PV, absent in secondary causes. Those are the big 3.
Perfect. Now, epidemiology. How common is PV in the UK?
It's pretty rare. The notes say about 2 cases per 100,000 people per year.
So not something a GP sees every day.
Probably not. And again, mostly older adults, median age around 60, 65. Slightly more common in men.
Okay, rare older adults, slight male bias. Got it. Let's move on to the clinical features. What does PV actually look like or feel like for the patient?
It can be quite varied. Common symptoms are things like headache, maybe dizziness, that persistent fatigue we mentioned, that characteristic itching, the pruritus, especially with hot water. And often an enlarged spleen, splenomegaly, which the doctor might find. Also, a ruddy complexion is quite typical.
Ruddy, like reddish skin.
Yeah, almost looks like they have a sunburn sometimes. It's called plethora. It's due to all those extra red blood cells near the surface.
And the big worry is the thrombosis risk, right? Clots.
That's the major concern. The increased blood viscosity, the thickness, really ups the risk of things like DVT, pulmonary embolism, stroke, heart attack.
Why the itching with hot baths specifically? Is that understood?
Not perfectly, but it's thought to involve histamine release from basophils, another type of white cell that can be increased in PV. The heat seems to trigger it.
Interesting. And the notes mention abnormal platelet function possibly leading to bleeding. That seems counterintuitive with high platelets.
It does, but sometimes the platelets, even though there are lots of them, don't work quite right. So paradoxically, you can get bleeding issues in some PV patients, although clotting is generally the bigger risk.
Okay. And high blood pressure is common too, about a third of patients.
Yes. Hypertension is frequently seen. Another finding is often a low ESR erythrocyte sedimentation rate.
Why is that low? Usually inflammation makes it high, doesn't it?
It does. But in PV, The sheer number of red cells seems to interfere with the settling process in the test tube,
Yeah.
leading to a paradoxically low reading.
And the disease can move from a plethoric stage to a spent stage.
Yes. Plethoric is the early phase with high counts. The spent phase, or post-polycythemic myelofibrosis, happens later in some patients when the bone marrow starts to scar down, leading to fibrosis. Production of cells then drops, and you can get anemia.
And some people are just picked up on routine bloods, no symptoms.
Absolutely.
Ah.
Which highlights why those blood tests are important. And again, thrombosis is the major cause of morbidity and mortality, so early detection and management are key.
What about less common things? Sweating, Budd-Chiari syndrome, peptic ulcers, erythromelalgia.
Sweating can occur. Budd-Chiari, which is clotting in the liver veins, is a rare but recognized presentation or complication. Peptic ulcer risk seems slightly increased. Erythromelalgia is that specific burning pain and redness, usually in the hands or feet.
And very rarely it could present as a heart attack or even spinal cord compression.
Extremely rare presentations, but possible due to clotting or extramedullary hematopoiesis, where blood cells form outside the marrow. And for women of childbearing age, the prothrombotic state poses significant risks during pregnancy: fetal loss, growth restriction, clots for the mother.
Okay. And on examination, what would a doctor look for?
That plethoric, ruddy appearance is key. Feeling for splenomegaly, an enlarged spleen, which is present in about 75% at diagnosis. Checking blood pressure for hypertension, maybe some tenderness over the sternum, though that's less common and might raise concerns about transformation later on.
Right. So symptoms, signs, and then the investigations confirm it. Let's talk tests.
Okay, investigations. The cornerstone is the full blood count, the FBC. That's where you'll see the raised red cells, hemoglobin, hematocrit, and often those raised neutrophils, basophils, and platelets.
And then the JAK2 mutation test. Crucial.
Absolute crucial. Major diagnostic criterion. You'd also check serum ferritin, often low because iron gets used up making all those red cells, and basic kidney and liver function tests.
What if JAK2 is negative and there's no obvious secondary cause?
Then you might need more tests. Maybe a direct red cell mass measurement, arterial oxygen saturation to rule out hypoxia, abdominal ultrasound to check spleen size accurately, serum erythropoietin level, usually low in PV,
Trey.
and often a bone marrow aspirate and tryphene biopsy is needed.
Bone marrow biopsy, what does that show?
It typically shows a hypercellular marrow packed with cells, often with increases in all three cell lines, what they call panamyelosis. It helps confirm primary marrow disease and rule out other things. Sometimes cytogenetics on the marrow sample too.
Okay. And those formal diagnostic criteria like
Yeah.
the WHO ones, they pull all this together.
Exactly. They use combinations of major and minor criteria. Major ones include the hemoglobin hematocrit levels, the bone marrow findings, and the JAK2 mutation. Minor criteria include things like low EPO levels. You need a certain combination to meet the diagnosis.
And there's this concept of masked PV, lower blood counts.
Yes, sometimes the counts aren't dramatically high, especially early on,
Yeah.
but the underlying biology and other features fit PV. It's important not to miss those cases.
So things like low ESR, raised leukocyte alkaline phosphatase can also be suggestive.
They can be supportive findings, yeah. Bone marrow typically shows that hypercellularity, maybe increased reticulin fibers suggesting early fibrosis. In the spent phase, you might see teardrop cells on the blood film.
So it's a puzzle, putting all the clinical and lab pieces together.
It really is. Especially for the JAK2 negative cases, which are only about 5%, you rely more heavily on the hemoglobin hematocrit, bone marrow, EPO levels, and excluding other causes.
Right. So once the diagnosis is confirmed, what's the management plan? What are the goals?
Main goals are control symptoms, reduce that all-important thrombosis risk, and ideally prevent or delay disease progression like fibrosis or transformation.
And phlebotomy, taking blood off, is central, isn't it?
Absolutely. Regular venesection or phlebotomy to keep the hematocrit below a target level, usually 45%, is the cornerstone of treatment for almost everyone. It directly reduces blood viscosity.
Are there medications too?
Yes. For patients considered high risk, maybe older, or with a history of clots, cytoreductive therapy is often added.
Like hydroxyurea or interferon?
Those are the common first-line options. Hydroxyurea, or hydroxycarbamide, helps lower all the cell counts. Interferon alpha can also be effective, especially in younger patients. Low-dose aspirin is also standard practice for most patients to reduce clot risk, unless contraindicated.
And what about JK inhibitors, like ruxolitinib?
They tend to be used more as second-line therapy or specifically for patients with very troublesome symptoms like severe itching or problematic splenomegaly that haven't responded to other treatments, or in cases progressing towards myelofibrosis.
So it requires regular checkups and monitoring.
Definitely. Regular blood counts are needed to guide phlebotomy frequency and adjust medication doses. Seeing a hematologist regularly is standard.
And managing specific symptoms, that itching?
Antihistamines can help. Sometimes SSRI antidepressants are used off-label for refractory itching, keeping baths cooler.
Mhm.
If uric acid is high, which can happen with high cell turnover and cause gout, then allopurinol is used.
And splenectomy, surgery to remove the spleen.
That's usually reserved for cases with massive, painful splenomegaly or recurrent splenic infarcts that aren't manageable otherwise. It has risks itself.
Makes sense. And the management differs based on risk, low versus high.
Yes. Low risk, usually younger, no clot history,
Mhm.
might just have phlebotomy, aspirin, and cardiovascular risk factor control. High risk usually needs cytoreduction, like hydroxyurea, added to that. If first line fails, then you consider second line agents like ruxolitinib or sometimes older drugs like busulfan.
Okay, a tailored approach. What about the long-term outlook? Prognosis.
With good management, the prognosis is generally quite good, but it is a chronic condition needing lifelong care. Median survival is often quoted around 14 years overall, but it can be significantly longer, maybe 24 years or more, for younger patients diagnosed today with modern treatment.
What makes the prognosis better or worse?
Age at diagnosis is a big factor. Having other cardiovascular risks impacts things. A history of thrombosis is a negative prognostic factor. Some studies suggest very high white cell counts might also be linked to poorer outcomes.
And the risk of it turning into leukemia.
The risk of transformation to AML over 20 years is relatively low. The notes say less than 10%. The bigger risks remain thrombosis and progression to myelofibrosis.
So managing clot risk is paramount throughout.
Absolutely. Ischemic stroke and heart attack are common causes of death, really highlighting the vascular risk.
Okay, and just to quickly recap the main complications.
Thrombosis is number one: DVT, PE, stroke, heart attack. Increased cardiovascular events generally, development of myelofibrosis over time, and that small but real risk of transformation to acute leukemia. Early recognition and management are key to minimizing these.
Right. So wrapping this up then, polycythemia vera is this chronic condition of blood cell overproduction, mainly red cells, usually driven by JAK2.
Mhm.
Key risks are around blood clots due to thicker blood. Diagnosis involves blood counts, JAK2 testing, maybe EPO and bone marrow. Management hinges on phlebotomy, aspirin, often cytoreduction, aiming to control counts and reduce risks.
That's a great summary. It's manageable, but needs lifelong attention.
Definitely. And it makes you think, considering how complex these signaling pathways are, what comes next?
Well, that leads nicely to the provocative thought. Beyond just targeting JAK2, what other future therapeutic targets might emerge from understanding these intricate pathways? Where else can we intervene?
Something to ponder. For listeners revising for the MSRA, don't forget to check out passthemsra.com.
And freezaway.com is another excellent place for high-yield MSRA resources.
Fantastic. Well, thank you for joining us on this deep dive into polycythemia vera. Hopefully that's clarified things a bit.